Okay. So I'm going to start off with our patient animation video. This is something you guys might be relatively familiar with, but it just gives a brief overview of what Blepharitis does before we kick into the patient aspect.
Itchy, scratchy, desert dry, teary, trashy, crusty sty, sticky, burning, makes you cry. You rub and rub and rub your eye.
Blepharitis, the most common eye disease in the world, and until recently, the most undertreated eye disease in the world. Blepharitis is the precursor of most lid diseases, such as dry eye disease, contact lens intolerance, and meibomian gland dysfunction, also known as MGD. Now let's go back and look at those eyelids again. Blepharitis is an overgrowth of otherwise normal bacteria living along the margins of the eyelids and lashes. This is the only place in the body that never gets washed your entire life. So over time, these bacteria build up and form a biofilm, like the plaque that forms on your teeth. This toxic environment makes for a perfect food source for a nasty little mite called Demodex. He makes the irritation and inflammation of the eyelids even worse. These biofilm bacteria begin to produce substances called exotoxins. These exotoxins cause the tear glands within the eyelid margin to become inflamed, which degrades the quantity and quality of the tear. Our tears contain our natural antibodies, so fewer tears results in even more bacteria in the biofilm, and a vicious cycle is established, leading to malfunction of the meibomian and aqueous tear glands, the glands most responsible for good tear production. Symptoms of blepharitis range from mild to severe and include foreign body sensation, irritated watery eyes, itching, crusting, eyes stuck together in the morning, grittiness, and the need to constantly rub the eyes. As the vicious cycle continues, the disease slowly progresses, eventually leading to dry eye syndrome. Historically, the only treatment for blepharitis has been scrubbing your eyelids at home with baby shampoo or other product. This treatment has never proved very effective, nor has it been accepted well by patients because home scrubbing cannot remove the biofilm. Prescription eye drops are equally ineffective since they also do not remove the biofilm, and they can be very expensive, which leaves only one temporary solution available: lots of artificial tears. This is not a good solution to the problem. Now, eye doctors have a way to break the vicious cycle of blepharitis and bring relief to millions of patients who suffer daily from this disease. Introducing Blephx, a revolution in the treatment of blepharitis and dry eye. The biofilm full of exotoxins that has been building up for years is now safely and effectively eliminated, removing the source of inflammation as well as the food source for Demodex. The procedure takes just a few minutes and is well tolerated. Most patients report an improvement in symptoms almost immediately, and many begin to make more of their own tears again. Blephx needs to be repeated at regular intervals to keep the disease from returning, much like going to the dentist and getting your teeth cleaned. By keeping your eyelids in optimal health, you should be able to keep free of blepharitis and keep your tear glands healthy and active for the rest of your life. Blephx is not covered by insurance, but you will find the procedure to be very affordable, especially when compared to the hundreds of dollars spent every year on ineffective prescription drugs and artificial tears. Be sure to ask your eye doctor if you might be suffering from blepharitis, and if Blephx might be right for you. Relief is finally here, so give your eyes a rest with Blephx.
All right, you guys, so that's essentially a crash course in the biology real quick and what the procedure does, which most of you already know. Here's where we get to the kind of nitty gritty, the how to walk a patient to yes, acceptance and closure. Okay, because with the methods that I teach you tonight, we'll be looking at an increased acceptance and close rate for your patients, especially with it being private pay. It does require a little bit more of a hand-holding process for them. So whether you incorporated it last week, last year, 2 years ago, or plan on it, I need you to understand something very important. You did not just buy a dry eye instrument and treatment. I'm not on the sales side, but I don't sell a dry eye instrument per se. What I sell is a new mindset and understanding of the dry eye and blepharitis process, and a new standard of care for your patients. And that's very important. This is a new standard of care. This needs to be a new baseline. There are three main ways in which Blephx can fail in an office. The first is staffing. Staff is not educated or trained to speak with the patients. I can't tell you how many times I've called an office and I've said, hey, this is Chris with Blefx. And the receptionist would say, hey, what's that? Well, it's fundamentally a problem there, because if I am a patient looking for Blefx and I've called your office, that's going to tell me one of two things. Either A, hang up and find somebody that does know it, or B, they're not doing a lot of procedures because the receptionist who's going to be scheduling out these appointments isn't familiar with the treatment. So we need to make sure that our receptionists have a baseline understanding of what Blefx is so that they can accept patients. Technicians or doctors are not confident with the treatment, not confident in their technique. Technicians or whoever we're delegating this to don't buy into the treatment. They see it more of a chore. We need them to understand that this is life-changing for patients. If we're doing this correctly, this is going above and beyond their current standard of care, which is lid scrubs. It needs to be known and recognized throughout the practice, from reception to partners, and this is very important. If you are a multi-doctor office, we can't have just one doctor, being the referral center for this new standard of care. We need all of our ophthalmologists, all of our optometrists to be buying into this new level, this new standard of care. Implementation. We don't know how to work it into the current flow. Who's going to be performing it? Doctors versus technicians. I just had one of the doctors asking that. So you guys feel free to answer her question in the questions tab here about delegation. Same day versus scheduling out. Blefx doesn't take a whole lot of time for the procedure itself, about 15 minutes, maybe 20 if we're really educating the patient, but sometimes that just doesn't work into a current schedule. We don't know how to educate patients about the procedure or the disease process. This is probably the biggest thing in terms of implementation where I see offices failing. Don't know how to price accordingly. Don't overprice yourself out of the market. In the same token, don't underprice yourself. You're providing a valuable service to patients. Make it worth your while. And then don't know how to talk to patients about the private pay aspect. Some doctors like to doctor, some doctors like to kind of put on that sales hat. You need to find, kind of going back to staffing, what works best for your office. Finally, technique. Poor or incorrect training, ineffective treatment will make for an unhappy patient. And we need to properly set the expectation. And I'm going to properly do that for you guys tonight. So when we talk to patients about Blefx, we can make it more correct in their mindset. So starting off, we are building a case against the patient, yet for the patient. Everything begins at reception. Okay, we need to start administering a speed test, which Blefx does include, and I've got it in the handouts. I can email it to everyone as well. This is important. The patient admits in writing to signs and symptoms. Okay, the handout that we provide, the speed test that we provide, just asks one question and has a list of signs and symptoms. You start making your way through it. Oh shoot, I do have crusty eyes. Yeah, they water sometimes. Yeah, my lids are red. Patient starts admitting these things and starting to build on them that, hey, maybe there is something wrong. And that is in their own words and their own writing. From there, our patient goes to the pretest area, where our technician that's doing their workup verbally gives the same questionnaire. This time, the patient admits now verbally to their signs and symptoms, emphasizing and enforcing the speed test. And doctors, techs out there, I'm sure you're very familiar. A patient will not tell a technician the same thing they will a doctor. Having the speed test helps continuity. Okay, it allows the patient's admission to go from written to verbal to now when we start doing our diagnostic testing. Obviously, mybography, osmolarity, T-butt testing, all objective information that compounds with the subjective input from the speed and technician interview. Put all this together with the comprehensive exam. Now the doctor has all this information with all other sources, makes for a more accurate diagnosis and an easier discussion for the patient. We have objective testing, we have their verbal admission, we have their written admission. From this point, really, it should be an easy case to close with them because they have all this compelling argument against themselves. Once again, we are building a case against the patient, yet for the patient. Now, when we talk to patients, and I hope you guys are using this model, but some of these are really going to simplify it, and I hate saying dumb it down, but when I dumb it down, it makes it easier for myself to understand. We have two models here. We have the oral model and the ocular model. And both can start off with an inflammatory biofilm. Just to simplify it, we'll call them both plaque. They both start off with plaque. Well, plaque on your teeth over a long period of time is going to turn into gingivitis, whereas plaque on your lid margin over a period of time is going to turn into blepharitis. Well, if we allow gingivitis to exist in the space for a long period of time, it's going to turn into gum disease. Same thing applies with blepharitis and this biofilm, this plaque. It's going to turn into dry eye disease. Well, what's our end stages with gum disease? Our teeth fall out. Well, in the ocular world, our tear glands and our lashes fall out. So essentially, we are talking about the same process. Well, let's look at some of the differences here. And I know that you guys can't answer, so I'll have my darling wife chime in with what she knows here. Doctor, who taught you good oral hygiene?
My parents.
Parents, absolutely. Education in terms of oral hygiene begins at a very young age. So parents, dentists went to school. It was enforced heavily. Well, our patients in the ocular space learn about good lid hygiene from their eye care provider, and usually it's after a diagnosis of blepharitis. Okay, so when does a patient first hear the word gingivitis? Doctor, when did you hear gingivitis for the first time?
I was pretty young.
Okay. Early off in life is when we hear it, whether it's through our parents, whether it's through our dentist, whether it's through those commercials that came on, watch out for gingivitis. It really personified it, villainized it, to the point where we didn't necessarily know what it was, but we knew that we didn't want it. Well, we need to think about the first time that patients hear the word blepharitis. Usually it's after their diagnosis, and they're usually diagnosed way too late, where it's an uphill battle from there. This is kind of an easy one. Are patients compliant with home care? Well, in the oral space, we are overly compliant, and patients with lid hygiene are notoriously not. My patients don't do anything that I tell them. They don't do their lid scrubs. Patients in terms of in-office cleanings, it's a routine sort of thing in the oral space, but it's relatively unheard of in the ocular world. So if we're talking about the same process, why are they miles apart in terms of compliance? Well, for all of you guys sitting at home that just yelled out education, that's what it is. Education is everything, and I need you guys to really put yourself in the patient's perspective. Right now, your dry eye and blepharitis syndrome patients are blindsided. They're absolutely just steamrolled. First off, they are blindsided with a diagnosis that they do not understand. They're sitting in your exam chair. You say you have dry eyes. They don't get it because they came in with a chief complaint that they're constantly watering. Okay, doc, I believe you. I've got dry eyes, whatever. Let's make some more sense out of this. How much is this going to cost me? Okay, how much is this going to cost me, and why doesn't insurance cover this? Well, they're blindsided with cost, and you have to think about it. Whether you're offering BlephX at $200 a pop, or you're offering a treatment plan that includes LipiFlow and BlephX at $1,000 a pop. These are expenses this patient wasn't necessarily planning on walking in with. I'm a man of metaphor here, and my truck, if I go into the shop with a tire leak and they look at me and they say, hey, Chris, you've got to get a whole new 4 set of tires. It's going to cost you $1,000. I'm not leaving there with 4 new tires. I'm going to shop around. I'm going to look at everything. I'm going to see I'm going to do a little bit of research. And that's what your patients do. That's why a lot of times they don't bite. They want to know why insurance doesn't cover it. And we are certainly going to cover that. I've got some questions real quick. We'll cover that, Sarah or Doctor. We'll cover how often patients repeat themselves. So I'll come back to some of these questions at the end. Here's something I hear a lot. My patients don't want to pay for anything. Okay. And they ask the question, does insurance cover it? I say no. No, it does not. And I emphasize to you guys, do not apologize. Once again, I'm going to divert to my wife over here. Hey, honey, if we're fighting and I apologize, what am I saying?
You are wrong.
I'm wrong. Absolutely. I'm saying that I'm wrong. And I don't want to admit fault. There's no reason for you to be apologizing to your patients for something not being covered by insurance. Insurance does not dictate what is medically necessary. Additionally, Insurance and medical treatment are not on the same timeline or trajectory. Mammograms were not covered by insurance for 30 years. Does that mean that for 3 decades they were not medically necessary? Absolutely not. It just means that insurance and medical treatment are not on the same timeline. Use that excuse. Blame me if you want. You know, say say this instrument has been around for a long time, but industry is just slow moving with it. But we need to take care of your issue today, because every day that passes is a day that we have lost to chronic low-grade inflammatory lid margin disease. My patients don't want to pay for anything. Well, if they don't want to pay for anything, why is Restasis Allergan's second best-selling drug after Botox? Global sales last year of 1.5 billion. First off, their number one best-selling drug is Botox. Patients will pay. Patients will pay. If they're freezing themselves in time, they'll pay. And additionally, you don't get $1.5 billion worth of sales without patients spending some money. And I understand that Restasis can be covered by insurance, but you ask your patients how much their copay is, and I guarantee you it is very costly to them. Most importantly, insurance does not dictate what is medically necessary. You or your doctor does. So don't be reliant upon insurance. Grab the bull by the horns and take care of your patient's inflammatory lid margin disease. And also, if patients did not want to pay, let me lead in with this slide.
Does this sound like you? Sweaty palms, high anxiety, deathly afraid to go to the dentist? Have you postponed your dental treatment due to fear? If so, we have a solution for you. We're able to help you complete dental treatment that you need, want, and deserve. Sedation dentistry allows our patients to relax and have dental treatment completed comfortably.
Okay, this slide should be very telling. The highlighted parts: don't expect sedation dentistry to be covered by dental insurance. Sedation dentistry, where patients are so terrified of getting their teeth cleaned that they will get themselves loopy out of pocket for $150 to $200 a pop to get their teeth cleaned. It says that first off, patients will pay. They'll pay for things that they understand. They're compliant with things that they understand. So we need to get them to the point of understanding what we're trying to accomplish with microblepharoexfoliation, with Blefex, with things such as LipiFlow, iLux, with manual expression and heat. They don't understand what's going on right now. Everyone's blindsided. My patients don't do their lid scrubs. I hear this one all the time as well. Well, these are actually two foams, lid scrubs, surfactant based, that come with the Blefex starter kit because we use them with the instrument. You can interchange these two out with nearly anything for this next demonstration. And I want you guys to really challenge yourself. Look at the instructions on any of your lid scrubs. All of them will say eyes should be closed. Close eyes gently. So if you've gone through our certification course or you've watched the biological background of the biofilm, you know that this biofilm or plaque covers the anterior and posterior sections. How can we expect at-home lid hygiene to be effective if it is designed for external anterior? These are designed to fail. So every time we say that my patients don't do their lid scrubs, we really need to assess what we're sending them home on. It's the equivalent of me being your dentist and sending you home to brush your teeth to prevent gingivitis and telling you only to brush the front of your teeth. Well, what's going to happen? You're going to get a plaque accumulation on the backside of your teeth that's eventually going to just run over the entire space. So we have to do better. We absolutely have to do better for these patients. Desperate situations call for desperate measures. So part of my role with the company is to embed myself in social media platforms and dry eye and blepharitis support groups, because I want to know, first off, what patients are saying about Blefex. It certainly helps. But I also want to know what they're saying about the treatment they're receiving, their eye care providers, their signs and symptoms. So let's go over some of these. I've read that castor oil can be beneficial for dry eyes, blepharitis, and MGD. Patients are putting a diuretic on their eyes and hope for relief. This one starts off kind of normal. Guys, for those who suffer from blepharitis, I would like to ask you some questions. Have you used wet ones? I've ordered some from the UK and I'm wondering whether to use them or not. But also, has anyone tried to wash their eyes with their own urine? And I get it. I get it. I mean, urine is sterile from the science aspect. I can kind of see where they're going with it. I don't want to know their process. Um, Here's another one. Yesterday, I started using my granddaughter's breast milk. It burned like honey eye drops, but I used it like eye drops. This is my latest try. We'll let you know in a few days how it turns out. Wish me luck is essentially how that one goes. Once again, I understand breast milk. It's heaven sent. It's like liquid gold, anti-inflammatory properties. It's just the fact that she started using her granddaughter. So how does that conversation come about? Did she look at her daughter as she was breastfeeding and say, hey, I need you to siphon some of that off for me? I mean, once again, desperate situations call for desperate measures. In response to that, this was the post, Jesus Christ, can we not? But somebody else chimed in to defend them and replied to their post, I don't see why not. After all, we've tried everything else. Desperate situations call for desperate measures. These are not patients that just out of the blue one day decided to do this. These are patients that were failed time and time again by the medical community because they were not offered a better standard of care. So I know that those are kind of humorous, but I wanted to end the patient interaction one with this one. It's from an article that was posted. Extreme dry eye left Fox News's Shannon Bream suicidal. I was in pain all the time. And you see, these patients are chiming in. I fully understand her discomfort and pain. Another one, me too. The constant dry eye, burning sensations, and eye pain are ruining my life. So this should really resonate. Your patients want better. They absolutely want better. These patients were allowed some way, somehow to get to this point. Once again, you guys, education is everything. Educating and raising awareness early leads to earlier acceptance. And that's one of the biggest things to take away from this entire meeting. Who benefits from Blepharitis? You guys, who benefits from a dental cleaning? Literally everyone. But we cannot realistically expect every patient to jump on board until the preventative model takes hold. Diagnosing and discussing blepharitis at the first sign of any lid inflammation will plant the seed. Not only do the symptoms compound and increase, but so do the costs. It becomes more costly to treat a late or end-stage patient than early. You guys see this all the time. You know, we need to look at this next patient right here, this example. And this is a patient that would not traditionally be diagnosed with blepharitis. They're not presenting with any scurf. The meibomian glands are intact, no heavy capping. It's a 33-year-old male. It's not symptomatic. Patient does not use prescription or over-the-counter aids. This patient is not presenting with plaque or biofilm. I want those terms to start being used because scurf, if you're still using it, it's a very antiquated term. I've got a quote from 1684 from Anthony van Leeuwenhoek, who is a Swedish physicist, I believe, which says the animalcules or bacteria in the scurf of a man's teeth are so many, I believe they exceed the amount of men in a kingdom. So 1684, Anthony van Leeuwenhoek was talking about plaque and using the terminology of scurf, and then the dental community wisened up and medically defined the terminology. We need to do that. There's no medical definition for scurf. What it is, it's plaque. It's biofilm that gets pulled off of the lid margin and oxidizes. So we need to let patients know that we need to remove the adherent biofilm with something like microblepharoexfoliation. This patient absolutely has blepharitis. They have inflammation right there, and they have edema or swelling at the lash follicle. So this is a patient that we need to look at and say, hey, and it's my eyelid. We need to say, hey, Chris, you have edema at the lash follicle. This is concerning to me, okay, because this is a progressive stage disease. It's going to get worse. And my recommendation today for you is to do a microblepharoexfoliation or a Blephx. And I don't know what you guys are charging, but let's say we're charging $150. So Chris, we can do a preventative treatment at $150, and you might only need it once, maybe twice a year. So we're talking about $300 cost. Well, let's say patient Chris says, no way, doc, I don't want to spend that. Well, this patient becomes symptomatic, starts affecting the meibomian glands. And next thing you know, patient's back in there. It's like, you know what, doc, you were right. You told me there were going to be signs. You told me there were going to be symptoms. You told me it was a progressive stage disease, and I'm absolutely feeling that. So what can we do about it now? And then doctor looks at patient Chris and says, well, the problem is plaque is now spread to your meibomian glands. We're going to need to do a lipoflow in addition to the BlephX. So instead of just doing a BlephX at $150, I'm now looking at a $950 treatment plan to get me back to the point where I should have been. So we need to start planting that seed early so patients are more willing to accept when they progress further, if you allow them to progress further. Set the expectation. BlephX is a medical procedure, very important. Recommend using an ABN, which that's one of the handouts that I have linked here. So if you don't have a BlephX consent form, let me know and I'll make sure you get one. Use PPE, personal protection equipment. BlephX is not a sterile procedure, but gloves and a face mask give the added perception of a medical procedure. Once again, correlating to the dentistry model. If I'm laying there in a chair and a dental hygienist comes up to me and she's not wearing gloves, I'm going to be taken a little aback. You know, this is a medical procedure. I have this expectation that this is something we're going to do. It makes it feel more formal, more professional. While BlephX can feel massage-like, this is not every patient's experience. Don't set this expectation. Let the patient know that there might be a foreign body sensation for up to 24 hours after. It's usually gone within 45 minutes, but I don't want to blindside the patient with a negative. Set the expectation and let them focus on the positive. Lighter lids, easier blink. Do a little bit of role playing here for you. Daughtry, if I were to say I'm going to do a BlephX procedure on you and not give you any indication on how it's going to feel post, and you got a foreign body sensation, it felt a little irritated, what would you think?
I would think that it didn't work.
You think something, yeah, something went wrong or it didn't work. So if I were to look at you and say, Daughtry, I'm going to do a BlephX procedure on you, you might have a little bit of foreign body sensation for the next 24 hours, and you got the procedure and you experienced that foreign body sensation, what would you think?
No, he said this would happen. It's fine.
Absolutely. You would reflect back on what your BlephX operator said there, that, okay, this is that foreign body sensation that they were talking about. It would allow you to focus a little bit more on the positive aspects. And even better, if I were to look at you and say, you could do a BlephX procedure, you might have a foreign body sensation, and you didn't receive one, wouldn't that be a win all around?
Oh, yeah.
So let's do that. Additionally, massages and spas are elective. If we're using this verbiage when we're trying to sell it to a patient, the patient will perceive the procedure to be elective. If I look at you and I say, Daughtry, I'm going to do a massage on your eyelids for 8 minutes, and it's going to cost you $200. What's your answer going to be?
I can massage my own eyes.
Yeah, I mean, if we're spending $200 on a massage, it better last longer than 8 minutes, and it better be all over my body, not just my eyelids, right? So if we use this vernacular, if we use this terminology, the patient's perception is going to be elective. And as we stated, it is a medical procedure. It is medically necessary. And this next part, I feel like I should get some sort of royalty or some sort of check from BNL. I recommend Lumify with every single procedure, not necessarily sending a patient home, but once again, correlating to that dentistry model. Once you leave the dentist, what's the first thing you do when you get in the car? You pull down that mirror, you look at your teeth. Oh man, they look white, they look good. You run your tongue along your teeth, they feel good. You get that immediate satisfaction, that immediate reward. It doesn't matter that 20 minutes ago you had a dental hygienist just beating the heck out of your gums, you were turning, you were spitting up a little bit of blood. You have your reward, and it makes it a great experience for you. So I do absolutely recommend a drop of Lumify after. Now that it's over the counter, I don't even necessarily tell my patients that I'm administering it, because I don't want them to use it as a Band-Aid. I don't want them to ignore their true signs and symptoms and just mask that redness with Remotidy. And two, I want to keep that a trick up my sleeve. I want them to associate all the positive with this procedure. Setting the expectation. Use the educational tools that BlephX provides. You guys should all have posters in the waiting room, pre-test, exam rooms, laminates. We've got those little handheld laminates. If anybody needs some, I'll have my contact information at the end of this presentation. Feel free to email me for them. Eyelid model and Demodex model. Those are a real hit with the patients and with your bedside manner talk. Lash cam, for those of you that have it, showing your patients their own eyes before and after is a real great seller. And obviously any other imaging diagnostic instruments that you offer, compound it. Give them a package on how you sell it. So I've educated my patient. I've discussed my treatment plan that includes the best standard of care. Patient is still declining. What next? What should I do? I'm telling offices to consider a waiver. And I say this from the bottom of my heart for the reason that I foresee within the next decade malpractice lawsuits springing up in terms of treatment of blepharitis and dry eye. The education is out there. Patients are very aware of the education. They are actively seeking answers that they're not getting from the medical community. So all they have to do to prove negligence is to show the delay in diagnosis and or treatment. Additionally, they only have to find that a reasonably competent and skilled physician would have acted differently under similar circumstances. That's a second opinion. How many of you guys see dry eye patients under a second opinion? Additionally, patients always use medical witnesses in the same profession to testify to this fact. So for those offices that are out there just absolutely killing it with BlephX, LipiFlow, have a complete dry eye practice established, you're setting the precedent that everybody needs to get to. And I understand that there are some outside factors in play, but that's the bar. And it's only a matter of time before patients are aware of that bar and they start going after the medical community that is not reaching that expectation. Let's talk a little bit about staffing. I don't know who Simon Sinek is, but customers will never love a company until the employees love it first. I took his quote and kind of made it my own. Patients will never love a dry eye and blepharitis syndrome treatment until the employees love it first. Okay? We have to get the entire staff involved. As a dry eye practice, you are now thinking outside the box. Continue to do so. Some of the best BlephX influencers did not come from an eye care background. If staffing allows, if finances allow, consider an outside influencer to be your dry eye counselor, your coordinator, or closer. Bring somebody in where it's their job to talk about BlephX, to be animated, to be passionate about it, and essentially close your patients. They don't need to know how to do the procedure. They just need to know how to talk to somebody about it and love it. You know, get the treatment done themselves. If they're a dry eye sufferer or BlephX has made a difference for them, consider that. People that have been awesome in this role, I've seen service industry, bartenders, wait staff, beauty industry, estheticians, jewelry sales as strong candidates. One of the offices that I just visited in upstate New York brought an entire team of closers that used to be in jewelry sales, and they do actually, I believe they are number one or number two BlephX users in the United States. So they put together a team where it was their job to sell BlephX. It was their job to sell their dry eye treatments. Don't plug somebody in the role that doesn't believe in making a difference. It's fatal to the cause. If they're doing it just because it's their job and not because they enjoy the treatment, you can't have them discussing it with the patients. Patients will sniff that like blood in the water to a shark. Don't make someone fit in the role if they aren't good for it. I talk to a lot of doctors, and a lot of doctors say, I discuss finances with my patients, but I don't want to. I don't like to. Well, that conveys to the patient. And if you don't have that mindset where you're comfortable talking about the finances, you need to figure out somebody in the office that can do it. Because once again, patients can read that, and they can read that very easily. On top of that, with this being a private pay procedure, I do recommend a closer that's not the doctor, because even if you're very comfortable discussing finances, that patient's still going to be wondering where this money's going. And obviously it's going directly to the office. It gives a little bit of a break between diagnosis and finances. So who to treat? And you guys, I promise we're almost there, and we'll be answering some questions shortly. Who to treat? Consider using BlephX for obviously any form of dry eye and blepharitis syndrome, and that's from early, not presenting scurf, debris, plaque, just has a little bit of inflammation and edema, all the way to lid laxity, entropy, and extropy. All these patients have a biofilm and can benefit from BlephX. All contact lens wearers, regardless of age, patients who wear fake eyelashes in between their fills, we don't do the procedure while they've got their extensions in. Punctal plugs, these patients already have a virulent biofilm. Patients with a prosthetic. Now I'm going to pause right there because I'm going to group all 4 of those together. All 4 of these patients, it's the same concept. We're introducing a foreign object into a target-rich environment for biofilm. These foreign objects don't have natural antibodies, so they are adhering more biofilm and exacerbating signs and symptoms, but doing nothing to protect the entire eye. And we see this all the time, contact lens wearers. You know, we're seeing dry eye and blepharitis in an earlier age. Yes, digital eye strain, but also the contact lenses that we're giving to them. I took my son to the orthodontist today. We've seen the orthodontist more than we've ever seen their dentist, and that's because orthodontists know that they've put a foreign object in a biofilm-rich environment, and they need to monitor it. They need to make sure that, well, obviously we're doing some adjustments, but we need to monitor to make sure that proper hygiene is in place, because we don't want this patient that's more susceptible to gingivitis to get it. Well, we need to start using that same kind of mindset when it comes to contact lenses. It's our responsibility. If you're writing the prescription, you need to follow up with good medical care to keep them in there longer. Patients who wear fake eyelashes, if they'll allow in between fills, and you'll see that a lot of times their lid margins, their lashes are gross, you know, and they need this BlephX in between. Punctal plugs, it's already virulent biofilm, and all we're doing is putting a foreign object in this toxic wasteland and kind of increasing their signs and symptoms. Yes, it's helping with the tearing, but is it helping with their inflammation and blepharitis signs and symptoms? No, just the tearing. Patients with a prosthetic, same concept as contact lens wearers. This is where one really resonates. Pre-op for refractive and cataract surgery, really any surgery, you're gonna have a better surface area for a surgical prep. In the webinar that we presented about the bacterial biofilm, a study was presented that showed after a routine and uncomplicated cataract surgery, the majority of the eyes, or lids rather, were still presenting with bacteria and biofilm. So what that says is we need to do a better job, better surface for that iodine prep, and do a BlephX beforehand. We need to further reduce the chances of endophthalmitis. This is a good one. Mitigate tear film instability. And for any of you doctors that are prescribing or doing premium IOLs, I've got an office in Calgary where the price of their BlephX and LipiFlow are built into their premium IOL. And the reason for that is because they don't want to do this procedure at $3,000 an eye, have the patient come back and still say that they can't see. Because you can't look at that patient and be like, well, you see, the thing is the reason that you can't see is you have a fluctuating tear film and you have 3 components of your tears. You've got the lipids, you've got the mucus, you've got the aqueous. Yeah, I mean, you've lost them at that point, especially when you look at them and say, well, it's going to cost $1,000 to regulate this tear film. So what they've done is they've actually packaged the price into their preoperative care for premium IOLs. What that means is that every patient has to pay for a BlephX and a LipiFlow. They can elect not to get the procedure and sign a waiver, but they absolutely have to pay for it, so they might as well, because they want to mitigate their risk and liability and variability with mitigating tear film instability. So let's talk about what's a fair price. I know a lot of people ask this. Travel all across the world. Most offices charge between $150 and $250. Charge according to your demographic and services offered. Like I said, don't underprice yourself and don't overprice yourself. Charge according to where you are and what you're offering. I recommend this right here. This is a sheet that you could give your closer. And I just slapped this together, so obviously yours would look a little bit more professional. But step 1 care. Okay, this needs to be your go-to standard of care. BlephX. BlephX is first, and there's different discount options that we offer. I've got an office in Canada where they offer unlimited treatments for 1 year, which is $1,000. Or, the doctor has recommended 3 BlephX procedures for you this year. So we can give you a pricing discount if you pay for all 3 of them up front. And if you see here, it reflects as $200 instead of $600. Or you can pay for a single treatment at $200. Look at a patient that's been diagnosed with myomitis, MGD, and then they're on step 2. the doctor's just diagnosed you with myocarditis, and he's recommended heat and expression as well as a Blepharitis. Compound it. If there are any offices out there doing heat and expression without Blepharitis, you are absolutely doing only half the battle. You need to compound it with the removal of the surface biofilm as well. And I don't know how you guys are pricing that, but you can work in pricing discounts as well. If the patient's at lacrimal or achilles deficiency, that's when we're at step 3, where it's going to require some steroids, a little bit. Still, we're going to require the heat and expression, still going to require the Blepharitis. So have them sell everything up front. Don't take it as we go. Don't allow the patient to slip further in the disease process. We need to make sure that we're being fair to the patient. So what is fair to the patient? Well, Blepharitis needs to be your go-to standard of care. Okay, needs to be your first step. We need to stop sending patients home on lid scrubs that don't work, on tears that are an absolute band-aid, just to see if a patient might get better. Our patients want better. You saw that. They're using breast milk. They deserve better. Okay, it's affecting their quality of life. If you already carry Blepharitis and other in-office services, you're already offering better. Okay, just stand behind your services. I run into offices where they're not giving the patient the option of going home on just lid scrubs. They're offering a better standard of care in their office, and they're saying, if that's what you want, lid scrubs are over the counter. Go there and get them. But we're not going to jeopardize the service that we offer just because you're looking to be economically sound. We are a dry eye specialty clinic, and this is what we have to offer. If you build it, they will come. If you offer a better standard of care than the office down the street, market the heck out of it, okay? You saw those patients that I was pulling from that Facebook group. They're looking. Obviously, their eye care provider is not providing what is needed for them, so let people know. If you offer in-office services for dry eye, put it on a bus stop poster. Put it anywhere. Put it on your social media. Don't hide behind it. Don't make it a secondary service. Make it a primary service that your clinic offers, and patients will come. They will absolutely flock to you, because there's a study that we reference in our biology webinar that says 1/2 to 2/3 of your patients, and this is a 2009 study, 1/2 to 2/3 exhibit some signs of dry eye or blepharitis. I'll take it a step further. It's 99.99% of your patients. It's not a matter of if, but when. So let them know that if and when the time comes, you are a safe haven for them. Pull your Restasis patients, anybody that you put on any sort of dry eye prescription, send them a personalized e-blast. Let them know the services that you offer. Offer them discounts. Become a part of the Blepharitis Concierge program. We are doing direct-to-patient marketing. And this is through SiriusXM. This is through social media campaigns, and patients are flooding me right now. It's in very remote areas, so I'm doing my best to pair them with Blepharitis doctors that are close to them. But all you have to do is send me an email that you want to be a part of it. And currently, all we're asking for you guys to do is offer them a first-time 20% discount on their first Blepharitis treatment, and we will route patients to you after already explaining the procedure to them. Okay, so that's actually the presentation. I'd love to answer some questions. I do have an email here. If anybody, A, wants a copy of the presentation, B, needs ordering information for supplies, Blepharitis, and any questions, my email, my cell phone are both there. I am a workaholic, so you guys feel free to call, email me really at any time. So I'm gonna turn this over so I can answer some questions. Maybe, there we go, questions. Okay, and I've got a question from one of my trainers. A couple of days ago, if you can use numbing drops on the lid margins via Q-tips. I mean, that's fine, but we really recommend just to drop proparacaine to anesthetize the globe. Proparacaine isn't really gonna numb the lids in its entirety. So it might, I don't necessarily want to agitate, especially with a Q-tip. Um, I just find it unnecessary. All right, and Rodney, it really just depends on the disease process. Um, Most doctors, here I'm gonna flip on my camera so you guys can see me. We recommend 2 to 3 times a year to stay ahead of the bacterial biofilm accumulation, because what we're doing is not sterilizing, we are debulking the bacterial loads to a lower population, so they're not as virulent. 2 to 3 times a year is what is recommended. Some patients might need it more. That's why, you know, that office does offer $1,000 all you can Blefx. Some patients might only need it, like myself, twice a year as more of a preventative model. Dr. Brill, nice to see you. No current deal on tips. We do have some end of the year deals upcoming. I'm not sure on what though, okay? Just keep your eyes on your email. And if you guys are wanting to be added to that Blefx Concierge program, just let me know and send me an email. Once again, with the email address that's displayed on the screen right there. And I don't know if it's Dr. Arbiter or must somebody with a medical license be in the office? That's I believe it's a state by state. I always find it most comfortable just to err on the side of caution and make sure that we do have somebody with a medical license on the premise. There's not really very many complications that could arise from Blefx, but it certainly always helps with patient, you know, patient perception. Let me see, who's it? Karina Snyder. Is this Dr. Snyder from Whitson? We have a bunch of studies that I can send you. I don't have them as the handouts, but just remind me, and anybody that would like a study, just email me. Once again, Chris, CHRIS, at blefx.com, and I will send you any of the materials that are needed. Trying to keep up with these questions. Many of my blepharitis patients are asymptomatic despite significant disease. How do you convince them that there is a problem? Dr. Fisher, first off, great to see you. I hope the patients that we've sent to you via the Blefx Concierge program have come in and been happy with their treatment. That's a great question. Asymptomatic. Correlate to the dentistry model, okay? And it's going to take some time. That's the big thing right now is we need to plant the seed early. And it might take a generation, honestly and truly. I mean, some people are just going to be so hard-headed. If they can't see it, if they can't feel it, it's not there until it is there. So plant the seed early with those asymptomatic patients. Let them know that they will become symptomatic, that they will cosmetically present this biofilm, this plaque, in which case they can be like, oh, shoot, Dr. Fisher warned me about this. I should have done something way back when. And then they will be able to educate their parents. Like I said, my parents taught me about good oral hygiene. The dentist just didn't wake up one day and said, you know, hey, we need to be preventative. They marched on it. They did an entire campaign, and that's where we're at now. So we need to be really hammering in this preventative model to patients. For offices offering unlimited Blefx treatments, how frequently should the treatment be repeated? I mean, it's really up to them. If you're offering it unlimited and they want to get it done, you know, once or twice a month, first off, it's not going to affect your profit there. It's going to be very lucrative. And if it makes them feel better, then it makes them feel better. Some of your more geriatric patients, even with the intermittent lid scrubs, they can't do a good job of it, or they don't want to do a good job of it. So this is something that we offer to help them. Lisa, a technique video. Send me an email and I can shoot you over the technique video. Additionally, and this is why I have a lot of my trainers here, we offer a training program where I'll send a trainer to your office to show you proper form and technique. It goes with a certification where we will certify up to 3 of your staff members on how to become a Blepharitis lid hygienist. Just like dentists have dental hygienists, they would be your lid hygienists. So this trainer would come on site with you, spend about 2 to 3 hours with your staff, go over the biological process, go over the hands-on, which is very important. Blepharitis is an easy procedure to do, but it does require a little bit of instruction. Okay, so send me an email if you're interested in that, and I'll let you know if I have a trainer in your area, and we'll get that organized for you. Additionally, we do have on our YouTube channel technique videos as well. Kenneth, your test kit is actually, it should have been in the mail, but send me a text after this and I will check with Mark and I'll get your tracking. What scrub is best to use with the treatment? Good question. It is recommended for a regular Blepharitis treatment to use a hypoallergenic surfactant-based solution. So that's where Lid Hygienics, the solution that came with the kit, that's where that comes in play. We can wholesale that. It's like $9 a bottle. It's a good fit. That being said, you can use OcuSoft products as well. I don't recommend tea tree oil products unless we heavily suspect Demodex. Okay, so we need to make sure that they do have Demodex, or clinically they're presenting in a way where we feel positive, because we don't want to associate that burning from tea tree oil or a mitricide with the sensation of Blepharitis. Let me see. Lose lashes as a result of the procedure. Blepharitis will, well, first off, if they're fake lashes, it will deteriorate the glycol. So that's why we say make sure that patients don't have makeup on, don't have fake eyelashes, don't have contacts in. Lashes, it's not going to pull out healthy lashes. However, we have seen lash loss due to diseased lash follicles. So we need to remove this biofilm in order to allow regeneration of lashes to happen. Social media content. Oh, I was supposed to lead off with that. You guys all do me a favor. Really simple. Blepharitis on Instagram. We post a lot of stuff there, and Blepharitis on Facebook. If you follow our social media sites, we often do ads that you guys can share, as well as just fun things that you can share to your page as well. Any office that we go to when we do our training, we try to take pictures there and then tag you guys that, once again, you can share to your social media platform. What technique would I do with very sensitive patients from normal patients? If we're talking about sensitive patients in terms of blinkers, I would use a little bit more of an aggressive hold technique with their lids. But everything just goes back to proper training. So Renewal, do me a favor, give me a call tomorrow and we'll talk a little bit about that, okay? Thank you, Dr. Solani. I didn't even say that you were here, but always a pleasure, sir. Let me see. I had a patient who did a Blepharitis and a week later came in and had acute keratitis. This patient refused medical treatment and thinks Blepharitis causes. Do you recommend we need an anterior segment of their SPK if you found may happen if this is not treated? Can you help out and maybe approach this type of patient? Jennifer, if you could do me a favor, if you can put that in an email and send it, and I'll actually have our medical staff address that. I mean, what we're talking about here is a PVA surgical sponge. So Blepharitis itself doesn't really have the ability to cause any major complications. But if you put that in an email, I will get you a formalized from our ophthalmologist that can answer that question for you and for your patient. Cleardex light foam spray, you can, as long as it's surfactant based and it's designed for that use. I know some offices will actually squeeze out the Clearadex hand wipes, and I don't recommend that. I want a more uniform concentration that's not as potent as Clearadex wipes themselves. But if it's a light foam spray with a surfactant-based solution, that should be okay. Recommend the scrubs. Jennifer, are you talking about the at-home scrubs? And I'll come back to that. Let me. Trying to fly through these, you guys. New Blepharitis marketing video coming soon. We've got some things up our sleeve, so keep your eyes open for that, Dr. Solani. And we do have some things on the horizon that are going to be really appealing for your patients. Seen an old lady have all the lashes fall out. Now, I mean, we'd have to look at her disease process. If she had if she was at lid destruction and all of her lash follicles were absolutely inflamed and destroyed, I mean, a strong gust of wind would have done the same thing. I don't think that anyone was pulling it out. It's just a matter of she had diseased lash follicles. Thank you, Dr. Pansy. Okay, at-home scrubs. That's it's like brushing your teeth, honestly and truly. I equate the lid scrubs to brushing your teeth. If they make your patients feel good, if they enforce compliance, that's probably the biggest thing. If they enforce compliance, then sure, recommend them. But as we saw, they don't need to be your go-to. None of the lid scrubs are designed to take care of the posterior section, and biofilm exists there. So we need to do something in office for these patients to take care of the disease process before it becomes more of a disease. Is that all the questions? Let me see, let me go to the top. Well, you guys, do we have any additional questions? You are absolutely welcome. Like I said, anybody, if you have additional questions that you don't want to ask here or come to you later, Chris, CHRIS at blephx.com. My telephone number is area code 270-791-8234. You can call me, you can text me, it doesn't matter. I will get back to you as soon as I possibly can. And this is across the board, whether it's questions about the procedure, questions about implementation, whether you need to place an order, I'll make sure you get to where you need to go with everything, okay? Well, it's been about 1 hour, and you guys, I thank you all so much for your time. We will be hosting another webinar. Not sure a date or time yet, but it will be covering the biology of the bacterial biofilm. So more of on a science and medical level of the disease process, and a more in-depth look at the dry eye and blepharitis syndrome new understandings. So stay tuned for that, and I will coordinate it. But you guys have a fantastic rest of your evening, and I look forward to talking to you soon. Bye-bye.